Have you ever wondered if there's a way to know if you're at increased risk for prostate cancer? What age should you start checking for this, and how frequently? These are all quite common questions, and definitely very important when it comes to early prostate cancer detection and saving lives from this disease. What many men don't realize is that even though they may not have any family history of prostate cancer, that they still may be at higher risk for prostate cancer because of their own personal genetics. We're going to be covering all of this and more here in a minute, so listen in. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. Well, it certainly will be a treat for our listeners today as we get to chat with an international expert on prostate cancer genetics, Dr. Brian Helfand. He is chief of the Division of Urology at NorthShore University HealthSystem in Chicago. He is also an associate professor at the University of Chicago. He received his medical training and Ph.D. in cell and molecular biology and genetics from Northwestern University. He is a fellowship-trained urologic oncologist who has focused his research career on prostate cancer. He has received multiple grants from the NIH and has published over 140 peer-reviewed manuscripts. His current research goals are focused on germline and genetic variations and mutations. He organized the first personalized prostate cancer clinic in the United States with the mission to implement genetic-based information to help guide prostate cancer screening and treatment decisions for patients and their family members. Dr. Helfand, welcome to the Prostate Health Podcast.
And thank you for having me. How are you?
Doing great. So Dr. Helfand, I think a lot of our listeners are curious to know, what are the risk factors or what are the known risk factors for developing prostate cancer?
So prostate cancer, when we use traditional clinical variables, clinical things to assess your risk, you'll typically walk into a primary care doctor's office or a urologist's office, and they'll ask you about your family history, your race, if you're African American, and certainly the older you are, the more likely you are to get prostate cancer. So of course we can't change race or age, and we certainly can't change our family history, but those are things that we take note of historically to assess your risk of prostate cancer.
Sure. So what are your and I know this varies, from association to association, but, what is your recommendation as far as, what age to start screening for prostate cancer?
So there are so many different authoritative views and actually so many experts, if you will, too many cooks in one kitchen to actually get a really unified view on this. So I actually think that there's pretty strong data to support that if you get a baseline test at an early age, and I personally believe, and my full disclosure is that I have a lot of bias because I have a lot of patients at high risk of developing prostate cancer, but I usually get a baseline at age 40. Okay, and that used to be the old National Comprehensive Cancer Network guidelines. And they really support that if you just have a baseline there and your value is lower than most other guys your age at the age of 40. So in that sense, it should be less than 0.7. And if it's lower than that, I say, hey, you're good for another 5 years. We'll recheck it then. If you're higher than that, I actually would start annual screening based at that point. But those are really kind of my high risk men that I'm paying most attention to. But even guys who think that they are low risk, a lot of them may have higher risk than they think. And so we can start screening at that time as well.
I think that's great. And, and with genetics and prostate cancer has really been an increasing hot topic lately. Now, you mentioned one of the risk factors for prostate cancer is, having a family history of prostate cancer. So when a man goes to see a urologist now, is just answering the questions regarding his family history adequate enough in determining his genetic risk for prostate cancer?
Right. So everything is changing, and certainly in the era of what we call personalized medicine, using your own genetics to help guide your treatment and screening decisions, things have changed drastically. And prostate cancer is the best examples of where we can use personalized medicine. And the reason for that is that prostate cancer is considered to be one of the most heritable genetic out of all types of tumors. And as such, we have historically captured family history as a way to capture or gain knowledge of who's at risk of that having that genetics. And family history is important, but we have to remember, especially as guys, turns out we're not the best in terms of knowing our family history or our medical history for that part. And certainly we have recognized that you should know your first degree relatives. So these are your brothers, this is your father, and their medical history to say, hey, did you have prostate cancer? But in the ideal world, we'd also know that about your paternal uncles, your father's brothers, cousins, things like that. And we just, as guys, and especially in the United States, we just don't talk about that at what I call the Thanksgiving table. And so it is important to not only know your prostate cancer history, but it also, if you're really going to capture family history, you should also ask about a family history of breast cancer, ovarian cancer, pancreatic cancer, endometrial cancer, melanoma, etc. And the truth is that not only do we not know about that, but we are really, as physicians, often feel rushed and we just don't have time to fully gather that information. So we, as clinicians, do a bad job. As patients, we have to understand that we don't do a good job either because we don't know that family history information. And that's really where genetics has come into play, is because it allows us to level the playing field. It allows us to say, hey, you may not know your family history, but I have the ability to measure something in your DNA that you were born with that will tell me, are you at risk of prostate cancer or not? And that way it allows me to really identify those high-risk individuals. Of course, that doesn't exclude the possibility that family history is not important, or it doesn't remove it, because we should still pay attention to it. It's just one of those where I think there's a better way, a more quantifiable way to measure your family history these days than just asking patients or asking clinicians to do that thorough job.
So when you kind of break it down and looking at, risk determination, kind of what percentage is made up in, based on family history or even some of those rare mutations? Is that pretty much it when we're looking at risk determination as far as what we look at? Or is there anything else that kind of comes into play here?
Right. So what we're getting at is if we're going to look at individuals and we're going to do a full assessment of your risk of prostate cancer, we really should be paying attention to three different things. Number one is your family history. Again, remember, family history is one of those variables which patients don't know about. We don't have a great way to quantify it. And that's really evident that if you look at a lot of studies and a lot of population-based studies, that only between 7 to 11% of men will actually report a family history of prostate cancer. But that doesn't mean just because you don't have prostate cancer that you are not at risk of prostate cancer, meaning that there are many men who don't have, in fact, the vast majority of men who don't have prostate cancer still may be at risk. On the other hand, is just because you have a family history of prostate cancer doesn't mean you're doomed or destined for developing the disease. It just means that we may have to screen you a little bit differently or more intensely, if you will, based on that family history. So again, family history is important. If we can capture a family history of prostate cancer, at least among brothers, fathers, we will count that, but it doesn't apply to the vast majority of individuals. Then there's what we call genetic testing that can get the other two parts. Genetic testing these days, in my opinion, really, it's important to assess two different things. Number one is there's a panel of gene that we can sequence. So again, we can take either a sample of your blood or a sample of your saliva, isolate the DNA. And this is the DNA, the stuff that's passed from generation to generation that you inherited from your mother and your father that makes you you and someone else them. And you can actually inherit some of the mutations in a specific set of genes that may predispose to prostate cancer, and some of them may even predispose to aggressive prostate cancer. I think the classic example that most people know about in this realm are what's called the BRCA1 or BRCA2, BRCA1, BRCA2 genes that have widely been associated with breast cancer. And that's, by the way, why we ask about history of breast cancer and other cancers, is because some of these genes in your family may predispose to breast cancer and other diseases. But if you look at mutations within a set of these genes, BRCA1, BRCA2, other genes such as ATM, CHEK2, a whole bunch of fun names, if you will, that they can give us an idea if you are at risk of developing prostate cancer and or aggressive prostate cancer. And if you have one of these mutations, it's important to know about it because, number one, it helps guide your screening for prostate cancer. If you have one of those, we're going to screen you earlier and potentially more frequently. If you do develop prostate cancer, it can help guide your treatment. These days, if you had an advanced kind of bad prostate cancer that has spread outside the prostate and having some of these mutations, there may be certain drug therapies that you should respond well to. It would also, if you know about these mutations, would help guide your screening for other cancers. And I always say, forget you as a patient, your family members as well would also benefit from that knowledge because it can help guide their screening. So it's very important to assess for the presence or absence of these gene mutations. Unfortunately, or fortunately, I'm not sure, that only about 2 to 5% of all prostate cancers can be explained by these type of mutations. So they're very rare, and we call them rare pathogenic mutations, which is a fancy word to say, hey, these mutation types in these specific genes don't occur very frequently. But if you do have one of those, it's important to know. The other part of genetic testing, it's cutting edge. So it is, in my world, been part of my research and my focus, but certainly now it's in the clinical realm, and there are a lot of available tests that now incorporate the next part of genetic testing, which would be a genetic risk score, or GRS. It's also been referred to as a polygenic risk score. And what these are based upon is that it turns out that every individual will have certain number of blips, if you will, throughout their DNA. These are little tiny variations that occur in every man, every woman for that matter. And there are certain blips. And by the way, the technical name for these blips is what's called a single nucleotide polymorphisms. Don't try to say that at home because you may get hurt. But these blips, as I said, there are certain blips that are specific for prostate cancer. There are other blips that are specific for breast cancer, heart disease, etc. And over the past decade and a half, not only have we identified their existence of these blips, but we now have over 170 known blips that are specifically associated with prostate cancer. We can actually count them up and create a score called the genetic risk score, which is compared to the average of the population. So as an example, if you have an average number of blips, you would have a genetic risk score value equal to 1, which means that you have average population risk, which for a white man in this country is about 1 in 8 chance of developing prostate cancer throughout your lifetime. If you had a genetic risk score equal to 2, that means you are 2-fold higher, or about a 1 in 4 chance of developing prostate cancer. And if you had a score of 0.5, you're 50% lower risk, or about 1 in 16 chance of developing prostate cancer. And so as such, you said, okay, you're increased or decreased risk. And additionally, there is a spread, meaning that of the age of diagnosis. So the higher your score, the earlier you are to be diagnosed with prostate cancer. So knowing this information, and every man will have a value, it's not like anyone doesn't have a value, is that you can actually guide a patient's timing and frequency of prostate cancer screening. So I don't have to look at you and say, well, you really have no risk, you have no family history, you don't have any BRCA type mutation, so therefore you're not at risk. No, I can specifically look at you and say, actually, your genetic risk score value is 2.4. You're 2.4-fold higher. And that just means that you have a very high risk of developing prostate cancer. And so we should start screening potentially annually at an earlier age. And in that way, it's a very precise and way based on your own DNA of how we can advise against or advise for or create a screening program for you.
That's awesome to have, that tool now available. And again, for our listeners, when looking at these blips or genetic variations, again, what he's referring to again is the prostate cancer genetic risk score in terms of some of those numbers in determining a risk. Now, Dr. Helfand, does this work with the PSA or is it even replacing the PSA?
So that's where there's always been some confusion. And I always get a lot of questions from both patients as well as urologists and medical oncologists. It does not replace PSA. It just means so PSA itself and other adjuvant tests these days are very good at detecting who's at risk or if you have prostate cancer or you don't, or who needs a biopsy. But what this does is it kind of is a very formal supplement, if you will, to family history. We say it's a quantifiable family history because if you look based on the genetic risk score itself, you can identify about 30% of men who are actually at increased risk of prostate cancer who have no family history. And all these men would have been missed if we just use the standard clinical family history, African-American race, et cetera, to just identify those who are high risk. There's increasing evidence that the genetic risk score is associated with, number one, lethal cancer. So it's not good at distinguishing those who have, run-of-the-mill cancer from lethal cancer. So we don't use it in that way. But certainly the higher your value, because you are usually diagnosed those tumors earlier, the increased likelihood of you not only being diagnosed with prostate cancer, but being diagnosed with an aggressive form. There's also emerging evidence to say that the higher your value, if you are diagnosed with a low-risk, non-aggressive type prostate cancer, the risk of you developing a higher grade tumor over time is also increased. And in that way, it's used to help also guide active surveillance decision-making. That's, for those of you who are not familiar, is that we don't treat all men with prostate cancer. A lot of men we actually follow over time with repeat biopsies and kind of say, hey, that I don't think your cancer would ever develop into a kind that would spread outside your prostate or hurt you. But inevitably, when we watch some men will develop more aggressive type tumors. And the genetic risk score is a tool that can also help with some of that decision-making aids as well. That's very cutting edge. That will be kind of coming out pretty shortly.
So kind of what you're saying is, we talked about with the high risk score, potentially at a higher risk of, higher, more aggressive disease or, higher risk of prostate cancer. So conversely, looking at those with the low GR score may be on the flip side, maybe have a lower risk then of prostate cancer death. Is that kind of what you're saying there?
Yeah, I mean, it actually is really cool in that way. Again, because everyone has a value. And we always pay attention to those at one extreme. So we say, okay, if you're high risk, that means we got to kind of screen you more intensively and make decisions based on that. But again, it's very precise and everyone has their own value. So if you're on the low risk side, you can probably decrease your screening. And it's also a decreased chance that you would ultimately go on to develop the disease. It does not mean that you don't need to ever be screened. It just means that there's a lower probability there. So in that way, the genetic risk score can identify really 60% of men. So for 30%, it's higher risk. For 30%, is lower risk. And that really is important when you look at men who think that they're doomed, meaning that they have a family history of prostate cancer and they say, I'm just going to get this. I know I'm going to get this. It's actually a very good tool to kind of calm them down a little bit. To say, hey, actually, I don't think you chose well. You chose the right genes and you didn't inherit that risk for prostate cancer. So we can kind of relax a little bit and decrease your screening.
So, I think a lot of people will be interested now in this test. Now, who is a candidate or in your opinion, who should get the test? Or is there anybody that shouldn't get the test?
So I'm very biased and a lot of these decisions are still in the kind of research realm. Although they are available clinically, you can get them from several companies, including Ambry Genetics. There's another company, GoPath, and then there's some other kind of more privatized companies that are now starting to offer this. And so I believe that everyone should have this test and all this information, not just for prostate cancer, but there are similar tests for heart disease, diabetes, et cetera. Because again, knowing that information and how we can screen because of what is in your card, so to say, again, these are not a guaranteed, it's just probability. So if you have an increased risk of a certain disease, we should just make sure that we screen you properly for that. So it's not a generalized screening for the entire population, but something that we can more focus in based on how you are built. So I think having that information early, I could argue in your 20s, your 30s, to just have that so we can get set up for that would be a good information to have. Of course, I don't think screening should start appropriately based on the disease type we're talking about. So again, on the earlier end in prostate cancer, I think age 40 is not an unreasonable way to start if you have a 5-fold higher risk of prostate cancer. On the other hand, is if you have a much lower risk of prostate cancer because your genetic risk score is 0.2, which I'm proud to say that's mine. But then the data would support that you really probably don't need to even start screening it before age 55 or so. So again, there is about a 10 to 15 year difference between the kind of the highest genetic risk score categories and the lowest one.
So does your genetic risk score change over time, meaning that, should we be getting this multiple times, or what your score is pretty much what it's always going to be?
Right. Because this is based off the DNA, which is taken from your parents, it makes up every single cell of your body. It does not change over time. So it's not one of those tests that you have to repeat. So therefore, a one-time test is all you need. Now, your risk of prostate cancer, the older you get, will change. So if you use that in what we determine a life remaining risk, then that value will change. But the actual score does not change over time.
And what kind of a sample for the actual GRS score, what sort of sample are they currently using for this?
You can do either blood samples or spit samples. I always think watching patients spit in a tube is always a fun activity. You sometimes get a potato chip or something in there as well, but it's very, very easy to do. And the other part about it is these days, genetic testing has become very inexpensive. It used to be back in the day, just to get a BRCA1 or BRCA2 test, it used to be on the order of about $30,000. Now you can get a full panel of genes. So again, those are the BRCA1, BRCA2, ATM, HOXB13, all of these type of analysis for all of those genes, plus a genetic risk score for under $250. So most men, even if they're not covered by an insurance, or they don't exactly fit the current guidelines for genetic testing, it seems reasonable. And most of the companies even have additional payment options if you don't qualify.
Yeah. Well, and especially with it being kind of a one-time test, if your score is not going to change, I think that'd be a pretty good investment myself.
Agree. And when you compare it to a PSA test, and of course, if you use a screening test, that's about $200. So for the same test, you can get a PSA, you can virtually get tested genetically.
Well, it's definitely exciting now to have genetic testing that can help identify men who may benefit from earlier and more frequent screening, and we're starting to near the end of our time here on the show today, but I know many of our listeners will want to learn more about the logistics of the GRS test, and Dr. Helfand will be sticking around just a few more minutes here after the podcast to answer some additional questions for the Prostate Health Academy, including logistics of how to get this test and the results. And, now the Academy's not live yet, but for those interested, just go to the prostatehealthacademy.com and sign up to be placed on the wait list. So in conclusion, Dr. Helfand, any final thoughts for our listeners today?
I'm just excited you guys are putting up with all my verbiage right now, but certainly I'm always around to help and have any questions. You can always find me at NorthShore University on our website. Always feel free to shoot me an email. I'm always happy to help guide patients, but certainly the more active you can be in your own health and be your own advocate, which is part of this whole process, is something that I fully support. And so again, always here and happy to help.
Well, thank you again for sharing your wisdom today on the Prostate Health Podcast. You've certainly delivered a lot of value for our listeners, so thanks again.
Thank you for having me.
Thank you again for listening to the Prostate Health Podcast. Follow me on Twitter and Instagram at gpullmanmd. Don't forget to join us next week for another episode.